Hello, everyone. Welcome to the Aging Games podcast. Today, I have Dr. Sande Bargeron here. We were just practicing her last name to make sure that I get it correct. And we're going to be talking about anesthesia. And this is a topic that is not often discussed at all. In fact, Dr. Sande's page is one of the only ones that I've ever found to discuss this really important topic and how it affects our mental health, our lives, our health afterwards, how we can detox from its effects. And we have so many things to discuss. So, Dr. Sande, welcome to the show. Thank you so much for being here.
Thank you so much for having me. It's such an honor to be on here and talk about something I didn't even know people cared.
Oh, no, it's
I'm kind of a unicorn in my world. So.
It's so important, and it affects basically everybody at one point in their lives. Dr. Sande, tell us a little bit about who you are and what you do and what makes you an expert on this.
So I am a medically trained, so in other parts of the world we don't have necessarily PAs or anything like that, but I'm a PA, and it's a US thing. I think we do have some in the like UK and a couple of places.
UK probably, yes.
Yeah, but my father-in-law, back when I had my MCATs done, I was going to medical school. He said he was a retired surgeon, and he said, don't go to medical school. Medicine is not the same. I don't like it. I wouldn't do it now. Mm-hmm. And I was like, okay. He said, just go to PA school if you want to be a health practitioner. And so I was like, okay. Mm-hmm. Well, I was very young. I was 20, maybe 23, maybe. Just married and with a baby when I went to PA school. And I quickly found out I hated medicine. So I'm glad I did just do PA school. Like, I hated it. I hated the philosophy behind it. I love medicine. I love that it provides a tool that's a useful tool to save lives and in that regard. But I hated the idea of, I got burnt out because I did not like that when I gave a patient medication I knew was going to cause a side effect, that side effect was going to lead to more medications, and our vicious cycle just kept going, and I never actually fixed the problem. And I was young and naive, and I still didn't like that, you know? Yeah. And so it wasn't very long into my practice as a PA working in ortho spine and joint. I did some pelvic reconstruction, and I did emergency medicine and things like that before I was like, okay, I hate this. What am I going to do? So I didn't know at the time, this is back in 2004 when I graduated from PA school, so I didn't know about any naturopathic schools. That was not something that was very popular at the time. It is now, but back then it wasn't. So I just was like, well, should I go back to medical school anyway, and then I can just carve my own way? And I was like, I just don't know if I can take it. Like, I don't know why I want to do that. And I had been working in the OR and ran into anesthesia providers and realized it was more than just MDs doing that, and that was a potential choice for me. And I thought, well, if I have to prescribe, at least I can do it in a way that's temporary, necessary, and useful for the good of mankind, right? Mm-hmm. Like, in other words, like, it's so much better that we have anesthesia today and we can do surgery safely and painlessly, right? Yes. So I could justify that position in the medical world. And I'm a protector of people. Like, my name even means defender and protector of mankind.
I love that.
It's kind of funny. Wow. I didn't realize that until years later, but I just naturally am protective of people. So in anesthesia, your anesthesia provider is probably the most protective of any of you than anybody else in your medical world. So now it's a short relationship. It's only for a period of time, but while you're there, they fiercely protect you. So just, if the audience is scared of anesthesia, just know that your provider is serious about that. That is a very kind of a cultural thing in anesthesia. So it was the right tribe for me. Yeah. And so I went to anesthesia school and I graduated and all that. And I had some autoimmune problems myself in my own health. And so when I graduated, with the stress of another school, it's very grueling. Medical training, I don't care if it's medical residency or anesthesia school, was hard. It was a lot of hours, a lot of information. And so I graduated and I was on baby number 3. So I had baby 2 somewhere in between anesthesia and PA school, and then baby 3. Wow. And my autoimmune problem, which was psoriasis, flared really badly, and the medicine no longer worked. And so then I was like, okay, naively thinking maybe they have changed the drugs since I've been studying. You know, I had to learn general practice medicine, so I was like, I know the drugs they're going to give me. I naively thought, oh, maybe in 2.5 years there's some new advancement and they're not going to put me on methotrexate or some like immune suppressing drugs. So I go to the dermatologist and they're like, yeah, no, we just have these new drugs. They're kind of like methotrexate. I'm like, I'm not taking a immune suppressant drug that causes cancer later in life. I'm just not doing it. So I just kind of resigned to live with it. And then a friend who was selling essential oils was like, I have some essential oils. And I thought, oh, that's cute.
What quackery. Oh my God.
Two medical degrees, and you're trying to tell me that essential oils are going to work when I've got like all the most advanced tools, right?
Yeah.
But she was a friend, so I was supportive, bought her oils, whatever. But I tried them because she gave me this book, and the intro about aromatherapy kind of read a lot like an anesthesia textbook. Just a little bit, because the way it talked about working in the limbic system, how it inhaled, anesthesia gases are inhaled. So I was like, well, that kind of makes, I don't know, maybe I'll try it. So I tried it, and they worked. And I thought, oh, okay, what else don't I know? And so that, I call them my gateway drug into natural health.
Your gateway drug.
Essential oils were my gateway drug into natural sciences. And so I started to research. Of course, I ended up in the gut health world. This is in now 2010, 11, so still a long time ago.
Yeah.
And it was a grace from God. I call it that happened to me because fast forward that about 6 years later, that child that I just had developed Lyme disease, and that's why I talk about Lyme disease. So it's the most complex organism on the planet, and it is very hard to treat, and it's hard to find people who understand the complexity of it and how it impacts every single system in the body. And I tried to find somebody, not be his doctor, and that kind of thing. I did the natural medicine doctor route, and I still just couldn't find a Lyme competent. They believed me about Lyme. They validated the Lyme, but they didn't know how to deal with the Lyme. So I just decided it was my obligation to take care of my son. So I went and got my PhD in natural medicine, and
as you do. What's what we do.
I mean, nothing makes you motivated more than your child. He couldn't walk. We were carrying him to bed.
Wow.
So it was a very debilitating neurologic type of Lyme disease. The first symptom was ADHD, which I thought was kind of interesting. And then when that settled down, it was like my knees hurt, my legs hurt, my head hurts, things like that. So his symptoms were more obvious as his inattention symptoms came down. But so that led me into natural medicine, and then so this is a long story. I'm sorry. I'm going to try to. I'm trying really hard to abbreviate.
I'm very interested in this.
And so of course I'm working in anesthesia, and I work with these medications all the time. I never really examined our drugs beyond what I was taught. We were taught about them, but we really, in medicine, what's interesting. This is something I say to people all the time who are medical doctors who come break it into natural medicine later. When we were in pre-med, I did all my pre-med courses. I had to do biochemistry, I had to do organic chemistry 1, 2, I had to do all of those things and learn all the chemistry and the biology and stuff that influences what we learn in medicine. But that stuff kind of gets dumped. We don't really look at that again ever. Really.
Yeah.
I mean, in medical school you build on it a little bit, but you really are learning diseases and pharmacology, which is a chemistry. It's a chemistry subspecialty, pharmacology is. But we don't go back and again think what is naturally occurring in the body. How does the mitochondria work? What influences the mitochondria? That kind of stuff. We forget that. We don't care. That was hard, and we don't want to think about it anymore. Okay. When I went back into my PhD in natural medicine, I was like, oh, the Krebs cycle, there it is again. So what we do in natural medicine or functional, holistic medicines, we actually go back to what does the body actually need and desire, and what can we do to support what the body is saying it needs, instead of band-aiding a symptom, which is what we do in pharmaceutical medicine. So I didn't actually look at the chemistry of our drugs until one day I walked into the OR, and a patient who was getting cancer therapy, she already had cancer. She had all the testing, and the interesting thing was, this is what made my brain go, wait, what? MTHFR showed up on her medical history list. So that's not normal. Like you get high blood pressure, high cholesterol, stroke, or something like that. A diagnosis is usually in there. But there along that was MTHFR, which is a gene mutation, right, that affects detox. And the interesting thing is I'd just written a blog for my website about that. And I talked a little bit about how it impacts anesthesia detox on the cellular level. And I thought, oh, wow, well, this has definitely caused her cancer. Now, does it impact her anesthesia? Has she had problems? So I talked to her, and long and short of it, it basically caused me to go, wait a minute. Now, what else are we not looking at in anesthesia? Like, do we have any discussion or research in anesthesia about, first, let's talk about cancer patients, because they're all going to have these MTHFR or methylation gene problems. They all do. That's what causes half of their cancers. So I'm like, okay, so are we considering that when we are doing clinical anesthesia? Like, are we talking about it? So I did this research, and I did find discussions, but I didn't see any studies, and it was just kind of like, maybe we should consider, have we all considered these kind of discussion boards that you have in professional journals? But it wasn't beyond that. And I started going, well, in my world, working with people, by this point I was working with clients in a holistic practice, doing brain health and Lyme disease and things like that, traumatic brain injury. I was like, this just doesn't make sense. Like, there is more going on that I'm not even thinking about when I'm in the space of anesthesia that impacts the brain. And now, how does this work? And so then that was 2 years of science research on how does the actual components of our drugs and anesthesia, the whole environmental, the whole experience of surgery, how does that impact all of those things that I was just saying, the mitochondria, cellular health, brain health, detox. And so that's what led to my book.
So tell us about your book.
So my book was really meant to be a guide, because people go into anesthesia and they don't realize that it's a very high risk environment when it comes to, we're over here trying to get microplastics out of our water, and we're fussing about xenoestrogens in our makeup, but the amount of toxic exposure in one surgery is so high that it doesn't really matter what you're doing over here. Do you know what I mean? And I was like, this is a huge event, and we're not talking about it. And if we're already thinking in the realm of like, how do I protect my body from all this toxic environment? Well, we need to know how to navigate something that is a naturally toxic event. And so I wrote a book called Breakthrough Anesthesia Fog, because the big thing that people complain about is persistent brain fog. Now, there is some shocking statistics on dementia in people that experience anesthesia after the age of 65, which is, they're shocking. Like 80%, up to 80% can develop delirium within a year, like that persists past 3 months after anesthesia. And those people are 3 times more likely to develop dementia. So that's huge, right? That's a big number.
That is huge.
It's not small. And if you take the brain of a woman who's maybe estrogen sensitive, hasn't been supported with her hormones, and their brain volume is already shrunk because of menopause, and you put that brain through anesthesia, it's even higher. But we haven't looked at these kind of things. It's not the nature of medical science. We haven't looked at that in anesthesia. But I have heard it enough that I was like, okay, I'm writing a book. and I'm going to give voice to the people who haven't been heard or have been dismissed as, that's not from anesthesia. That's not, that you just got some brain fog. And it basically gives a guide to how to prepare for anesthesia, like pretending it's a marathon, because it is a big event, like a marathon. Preparing 3 to 6 months ahead of time, exact strategies like the day of and around surgery, and then for like 3 months after surgery. So it's really to restore your cellular health, detox you properly, and make you have least amount of symptoms that last a long time, and lower your risk for long-term, like dementia and things like that. So that was a long.
That's totally fascinating. And I mean, and the fact that nobody's talking about it, and also the fact that it's the most vulnerable people that are being put under, that are already have like a compromised immune system and all kinds of health issues, and then this on top of that, and then to be gaslit after and saying, oh, your brain fog is whatever, menopause or something else that is not related, is just unbelievable. And like I said, this is, I mean, of course I knew deep in my heart that those drugs are not good, but I never realized.
I think everybody kind of knows.
Yes, I'm sure.
I hear it. I'm not
Yes.
scared of surgery. I'm scared of anesthesia. Please make sure I wake up. like,
Yeah.
like that's what I
Yeah.
hear. So I understand.
Yeah.
I think people
It
have a
is.
natural understanding that's not necessarily good. But,
No. And I
yeah.
mean, like what blows my mind is like what actually happens to us during anesthesia? Like where do we go? What happened? Where are we? Are
I
we
love this
dead? Are we
question.
alive? Are we in
I love this
between?
question.
Where
Okay,
are we?
this is like a really philosophical question. It kind of. This is where medicine and physics and philosophy all intersect. I remember I just graduated from anesthesia school. I think back to this time that somebody asked me that question the first time. So I'm very much, I was in a, I was friends of someone who was an art student, and she was in a big art school in Savannah, Savannah College of Art and Design, big international art school. And around a bunch of these kind of art students, and I'm a science brain,
Yeah.
very different thinking, and I just finished anesthesia school. I was so thankful to be done. And, I felt pretty confident in my skills to do anesthesia. I'd been in medicine a long time. And somebody asks me that at a party with these art students, and they're like, "So, where do we go?" And I was like, I don't know. I was like, I haven't even thought about that. I just turn your brain off. I don't know.
Yeah.
But fast forward, I of course, the longer you're in a profession, the more deeply you think about it. And anesthesia is interesting because there is an anesthesiologist who I follow that I really love his research, but it's beyond my. I'm okay smart, but like that guy's like crazy smart. Okay,
Wow.
like he went into anesthesia to study consciousness.
No way.
So back in the 70s, this guy Stuart Hameroff, he was like in medical school, and he was gonna go psychology. Thought that was psychiatry. Thought that was gonna be the way to study consciousness. But long and short of it, he decided a professional told him, if you want to understand consciousness, study anesthesia, because we selectively turn off consciousness. And your body's still alive. How do we do that? And I actually had this conversation with one of my students recently. I said, "So how does our anesthesia drugs work?" And I knew the answer I was going to get because, we are taught it works on GABA, and it stimulates GABA, so it turns down the neurons. But so does lavender essential oil, Versed, Klonopin, a lot of things work on GABA, but they don't block your consciousness. And consciousness is not a biological phenomenon. It's metaphysical.
Exactly. Exactly.
So here's what Hameroff's basic, and I'm going to do my best. I am not a quantum physicist, but that's where we go with this conversation.
I love it. Let's go.
He has studied. So there's this monitor I use on people that you might have seen when I did one of my reels on my average day in the OR. I use this monitor to put in people's forehead, and it measures your beta, theta, all these delta waves that when you're asleep you go into certain waves.
Yes.
And it's measured in hertz. So we can see how good in a sleep you are based on how the frequency that your brain waves are giving us. He had monitors, because he was studying consciousness, he had monitors that measured down to the picohertz.
Wow.
That's like really fast frequencies, really, really way down low. Like we're talking down to beyond the neuron. And what he discovered was on each neuron, there's something called a microtubule, okay? And to give you a visualization of that, if you can remember way back to like early biology that you learned in grade school, when you learned the cell division, there are these little fingers that divide, like you see them in metaphase right there. Those are microtubules, okay?
Yes.
They're still connected to each other, but they're two separate cells. We have those on each of our neurons, about 1 million per neuron. And what he discovered is when we give an anesthetic, we basically turn off the frequency of those microtubules. And the thing with those microtubules is that they fire at a quantum frequency. And what he then determined was that since it's quantumly firing, it's firing at a quantum frequency, we're quantum entangling, and we're making moment by moment reality decisions. Like this is where we can go into like, is it God determining, or is it we're at multiverse? That's where now we're intersection with like philosophy. So is quantum that quantum firing is what creates consciousness, not the neurons sending signals between each other. So that was Stuart Hameroff's theory on it. And what's interesting is other people have since studied that, and they found like there's certain medications that will stabilize those microtubules. So when you do that, you take those medications. One of them is a drug that we use in cancer called tamoxifen. Mm-hmm. So if you stabilize it, you give somebody tamoxifen, you can't get them to sleep as quickly. The medications don't work as well because they're stabilizing the microtubules and they're still firing. And so it needs more drug to turn those So it proved the microtubule theory, which then leads to, quantum physics, multiverse, or whatever realm you want to go from quantum physics. So isn't that wild? There you go.
It's so wild. And that topic fascinates me so much. And last time I was under, and I was waking up from general anesthetic, and I was like coming back into my body, and I was pushing it away, and I was like, no, like I did not want to come back. Like
oh wow!
So I
you
don't
were
know if
so at peace.
I was at peace. I was out of here. So I really wonder, like, okay, if you were disconnecting from the consciousness of the person, is that consciousness leaving during surgery and off to a different realm, or are we
it is
like
a quantum phenomenon? So it is definitely something.
It's really interesting. It was so fascinating to me, and I woke up and I did not want to be here. I didn't want to be back in my body, and I since then I've been thinking about it so much. Like, where did I go? Where was I? What happened? And I wasn't even supposed to be put under. It was supposed to be local anesthetic, but it was a Spanish hospital. They misunderstood me. And it was just so weird that, that this could happen, right?
Right. It's wild.
It's really wild. It's really crazy. Yeah. So Sandy, let's talk about menopause, because the brain works differently. Like, there are so many changes and everything that we go through during menopause. So why is it that if we go under anesthesia that the effect is so different? And what do we have to be, is there something that we need to be careful with?
Yeah, so this is a great question. And it's near to my heart as a perimenopausal woman. Yeah. I don't, first of all, I don't like to scare people, by the way. This conversation is about empowering people to know and to be validated if they had these experiences. So just disclaimer here. But as we go into perimenopause, which starts at 35 biologically, the changes leading to perimenopause start around 35. Meaning we start to decline in our progesterone, right? Yes. And then as we actually enter more middle of perimenopause, we're starting to decline in our estrogen. And then we're in postmenopause, we've got low estrogen, low progesterone. Now, why that matters is progesterone is a really important hormone for our brain. It's a neurohormone by itself. Actually, the neurons make progesterone to some degree, so it's kind of interesting. We can't measure all of our progesterone because some of it's made directly at the organ site. But progesterone is also I call it the parasympathetic hormone. So it's the rest and digest, the calm down hormone. It's the opposite of fight or flight. And so if you are a perimenopausal woman, you can testify that at around 35 or 36, you start feeling a little more anxious. You're having a little more problems sleeping, maybe a little more constipated. Yeah. And brain fog is just creeping up. Weight is starting to creep up. Why? Because you're in sympathetic dominance. Your progesterone is declining and parasympathetic and that is completely because of your hormones, not because necessarily you could be living your best life, not working, loving it, and still this is happening because it's a biological phenomenon. So when that happens, progesterone is also an important hormone to turn on certain mechanisms inside the cell. So in fact, those mechanisms are involved in detoxification. So they downregulates glutathione production and certain other detox pathways that are needed to move toxins out of the body, which is, in my theory, I haven't really actually looked to see if the studies support this, but in my theory that supports why cancer often occurs in women post 40. Like the highest density of cancer, because think about it, you can't detox well because progesterone first is declined. So now you're going under a very highly toxic experience. You're getting, and it doesn't matter the type of anesthesia unless you're just strictly doing local anesthesia. If you get anything that gets systemically given to you, whether it's gas or IV fluids, IV medications, The body has to clear it.
Yeah.
And if you don't have as much progesterone, that's going to be a slower process for you. So yes, by nature, that leads to more brain fog, slower clearance, longer impacts from those drugs. That's just natural. But now we add in the estrogen decline part. And when estrogen declines, now we're actually losing brain volume. And our brains are more vulnerable. I think of a client I had who had a traumatic brain injury. And she had never been on hormone replacement, she was the unfortunate victim of the like the big black box warning that happened, because that was unnecessary. I always thought that was stupid, but I was a PA back when that happened. I was like, I don't know. This is what they're saying. I don't know, but don't we need estrogen? So anyway, unfortunately, she never had been on it. And when they MRI'd her brain before I was working with her, there was just a ton of, it looked like an aged brain. Like the volume of the brain has shrunk. And the cool thing is, with bioidentical hormone therapy, you actually can revolumize your brain. Now, why that matters in anesthesia is that you already have a decreased volume of brain, which means aged brain, scarring, less communication. And now we give you chemicals that basically, similar to a traumatic brain injury, create an inflammatory response in the brain, which actually leads to more decline in volume of the brain. Yeah. So we just have, unfortunately, because our hormones shift a lot in our midlife, have like a lot of reasons why anesthesia is going to cause an impact on the brain that's persistent and stubborn and difficult to weed through.
Yeah. So do you find that women who are on BHRT or HRT do much better after anesthesia? They don't have so many issues.
Definitely, if they're unbalanced. BHRT. I don't usually recommend synthetic hormones of any sorts, even HRT. So I'm not a big fan of anything synthetic like that. Premarin is pre-marin. It's from the urine of a horse urine. Horse. I'm not a huge
fan. Can do better than that.
Yes, we can. But I do find that it is somewhat neuroprotective to have your hormones balanced with bioidentical hormones, especially progesterone. Which is usually missed. I see plenty of people. I'm on hormone I'm on estrogen. I got an estrogen patch. I'm like, great. So you're just more sympathetic drive now. What about the progesterone? They're like, they didn't put me on progesterone and testosterone too. But we actually can make testosterone from other means, like it's a downstream produced hormone. So we can often make it from our DHEA and sometimes from our estrogen. So I'm very careful about like how much yes, we should have some testosterone, but I'm slow to, like, personally in my clinic, I'm slow to say I think we should add testosterone. I add it last.
That makes sense. That makes a lot of sense to me. Can you tell us a little bit about what the difference is between gas and IV anesthetic?
Oh, and I didn't mention methylation. Sorry.
No, tell me methylation. That's important.
Put the pin in that, and I'll come and answer that question. So the other part in menopause that happens that most people don't know is that because the hormones shift, we actually start activating, the genes we have that regulate methylation start to be less efficient. Okay, so we start to naturally develop methylation problems. So even if you don't test for MTHFR, that's just like the one that everybody knows. But there's a whole lot of genes that methylate. There's a lot. I talked about that in one of my reels. Like, this isn't the only gene. These genes matter too, you know. But in perimenopause, like, because our hormones influence our genes, this is a cool thing. If you didn't know this is a fact you need to know. Women have 1,100 more genes than men. 1,100 more genes.
Why is that? Is that for reproduction?
Those genes they influence how our hormones are managed, and they are influenced by our hormones. It's something to do with our hormone landscape. 1,100 more.
I always knew we were special.
So yes, so it's crazy. So imagine those 1,100 genes they have a kind of a relationship with our hormones, and our hormones are now dysfunctional. Now those genes don't work as well. Do you see what I'm saying? So that's another piece that influences how we detox is methylation. So when that starts to decline as well, we end up with
more
more
issues. You
issues.
mentioned glutathione earlier. Is glutathione something you would recommend after anesthesia for detoxing the body?
So I tell people that this is like probably the number one question, probably because I've seen a few people who are not anesthesia providers who are in the holistic space advocating for glutathione before surgery.
Yes.
And, there's a big market to an IV
Yes, it's
clinics
huge
doing
right now.
glutathione.
Yeah.
And so I always kind of, I'm not skeptical, but I have a healthy degree of skepticism. Like, yeah, it's something you're also selling, like,
Yeah.
I mean, you end up creating products because there's a need. I mean, I did it too. So, but at the same time, like, make sure you know what you're saying. And I get a little bit irritated when it's like somebody who doesn't understand anesthesia saying, get an IV glutathione. We should have glutathione before and after surgery. I'm like, well, that's not going to, that's really not, I don't think you know what's involved in anesthesia. So glutathione is amazing, especially in perimenopause, because we start to have, like, because progesterone declines, we decline
Yes.
in our glutathione expression. And so we do benefit from glutathione in the sense that it'll help reduce our overall toxic burden that we're already stuck with, like we aren't getting it out already before surgery.
Yeah.
So in that way, I find it to be helpful to use glutathione. I don't do IV glutathione. I feel like I can do it cheaper sublingually with certain products. So I don't recommend the expensive glutathione IVs, but glutathione is helpful, and I use a lot of glutathione in my practice. Don't get me wrong. But if the goal is to clear the fluorine molecules that you were exposed to at a high level under anesthesia, that is not what glutathione is going to do. It doesn't capture those molecules. Those are halide molecules, and they work very differently, and they're just simply not removed from glutathione. That said, glutathione still supports the immune response and detoxing from other things and just overall health, so it's not bad. It's just not, if the question is it detoxing my anesthesia, the answer is no.
And your post today on Instagram was incredible about the different medications, and if somebody was on Cipro or some of the other antibiotics beforehand, then the side effects could be even worse and the effects much worse. Tell us a little bit about that. And it's really interesting because I was just interviewing this lady last week who was almost killed by Cipro. And then, then I'm sure she had to have surgeries and things like that. And then all of these things compounded will just make the situation much worse.
Yeah, it's another one of those things where it was an accidental finding. Like, they don't teach us this in school, and it's part of the molecular structure of the drug. So it's not, I had somebody say, I looked at the ingredients, fluorine's not listed. I'm like, that's because it's part of the molecule. It doesn't need to be listed as a separate ingredient. It's part of the molecule. And she's like, oh. Well, I stumbled on this because I have 5 children. My oldest is 24. He is I call him the victim of my medical degree, because he was the 6-month-old I had when I was going to PA school, and he came out of the womb extremely ADHD. I mean, he came out spinning like he was ADHD. He had a traumatic C-section, all the things. I mean, I could even look at my anesthesia and wonder how much that influenced it, and my lifestyle, diet, blah, blah, blah. Yeah. But he, I really, truly did look. I was like, is there any research that supports other healthy, natural ways to manage this ADHD? Because it was ridiculous. I mean, truly, they wouldn't have taken him. They sent him home one time when I didn't give him medications from his school because the teacher was like, we can't handle him. It was so bad. But long and short of it, I put him on Vyvanse when he was 4 years old. So this is an amphetamine drug that I put my 4-year-old on. By the time he was 8, they put him on Prozac as well, which is one of them fluorine drugs. Yeah. And by that move, I was like, we're going in the wrong direction. And so I pulled him off of that Prozac. By the time, within 6 months, I was like, this is not right. An 8-year-old should not be on Prozac. You can't justify this. Give me a good explanation. And they really didn't have good explanations, which was the worst part. The pediatric psychiatrist didn't have a good, chemical, physiological, give me a real scientific explanation of what we're doing here, what this is achieving. And she didn't really have a good one. But the point was, by the time I started questioning, like, okay, why are we going Prozac? What, and then when I had my essential oil gateway drug experience, I started to look at drugs, and I started going, I really want to get this kid off of his amphetamines. And somehow I ended up pulling the package insert of the drug out and open that 50-page thing, and I was like, what's in here? Like, is there anything I need to know about the structure? I mean, I'm starting to think like a scientist, like what else is in here? And I will be damned, but there was like blue 40, yellow lake something in there, like all these dyes that we know cause inflammation to the brain and make ADHD worse. And I was like, is this on purpose? So people keep taking these drugs. I really was like having an existential crisis in medicine, going like, if they get the dye in the drug and then the drug wears off and they rebound and they're very ADHD, well, that's positive reinforcement for me to take that drug tomorrow. Do you know what I mean? Like,
absolutely.
I'm like, this is ridiculous. What else is in these drugs? And so I look at Prozac, and then there's fluoride in Prozac. And I was like, what the blankety 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 blank?
I hear
and
you.
So it was a sudden like, oh my gosh, that's actually a fluoridated molecule in here. Fluoride, I just was working, this is like 2012. I'm like trying to defluoridate my water. I'm trying to detox them from fluoride because I've been giving the kids tap water. I didn't know anything. I was an idiot. And so here I am, like, there's fluoride. I'm like doing all the things. I'm killing myself, and it's fluoride in the drug I was giving them. Oh my gosh, what other drugs are in there? So then I found albuterol, and I was like, what? And it just went from there. So this is research I have had for over a decade. I've been looking at it for over a decade. And it wasn't until I made that connection with anesthesia being it's a very different type of fluorine exposure. Mm-hmm. So we're in the drugs like Prozac and Prevacid and Lipitor, where we have fluoride embedded as a salt to stabilize that molecule and drive it deep into the tissues. In anesthesia, it's a gaseous fluorine, non-stabilized, so it will go very deep into the tissues and very quickly, and that's what's different about it. So that's also what's different about Cipro. Cipro is just uniquely structured. So this is very much biochemistry, organic chemistry, a little deep maybe for the average listener, but bear with me. Where the other drugs like Lipitor and Prevacid have it stable into a salt form in their chemical structure. It's sort of a stable fluoride. Cipro holds fluorine in like an aromatic ring, and so as soon as it enters the body, it actually becomes sort of like a fluorine molecule, kind of more like anesthesia. Mm-hmm. And so that's why it gets deep into the tissues very quickly. It's meant to do that, to drive the antibiotic deep into tissues and help you recover and kill the infection faster. That's the thought behind that. Mm-hmm. But that's why the side effects are such a thing. And that's what made me go, if ciprofloxacin does that, and anesthesia is the exact thing, mm-hmm. Wait a minute.
When you combine,
I made connections that I don't know if anybody else is talking about, but that was just like, and it was going back to the pre-med curriculum. Do you know what I'm saying? Not medical school training. This is pre-med. I'm going like, oh, this is important. This is really important. This makes sense, and it explains a lot of things.
Do you get any slack for speaking out about the things that you speak out about?
So that's a great question. So far, I'm waiting. It's coming. It's coming.
And your colleagues?
So I don't personally talk about this stuff at work. Sometimes I have I work so I'm a certified anesthesiologist assistant. That's a CAA. It's like a PA version mm-hmm. of an anesthetist. In the world of anesthesia, you got to know this as context. You have an anesthesiologist, MD, who's done a lot of time, okay, medical school residency and anesthesia residency. So there's a lot of training, very smart people, very dedicated. Then you have a certified nurse anesthetist, okay, and then you have CAAs. Now, we make up the smallest percentage, CAAs make up the smallest percentage of anesthesia providers because we're relatively new. CRNAs are the nurse version of what we do. And they've been doing anesthesia before it was an actually medical doctor degree. So they were the predecessors of anesthesia back in the day when it was just a tech did it, right? And the nurses are just techs, you know.
Yeah, of course.
I just think it's ridiculous. But there is like, CRNAs they don't really love AAs for whatever reason. I don't know why. We don't pose a threat, but they're kind of threatened by us, and they have a lot of vocal anti-CIA rhetoric, which is very frustrating. And so I have had a few people who are CRNAs come on my page and say, don't call yourself an anesthetist. And I'm like, well, what do I do that you don't do? I push the drugs, I give the drugs, I manage the patient.
Yeah, exactly.
Are you just politicized here? Like, what's the... So I just block and delete these people. So I get a little bit of that, but I have had plenty of people in the same vein that are nurse anesthetists, NDAs, and everybody kind of comment in there. In fact, this morning, I opened my Instagram, and Dave Asprey followed me.
No way! Oh,
I was like...
amazing!
What?
That's so cool.
How did I end up on his feed?
Wow.
Gosh. I was like, so I don't care.
You made it, girl. Here at the show. That's so cool.
Dave Asprey, what the heck? Biohacker,
Wow, that is so cool.
So it's funny. But when it comes to speaking out, like, I'm sure I'm going to get it. Anesthesia, I had this colleague. So funny story, if you have time for it.
Of course.
My book was officially called, like, Getting Over Going Under. That was the initial title. I was working with a company to help do my publishing, navigate the publishing thing. So I'm writing the book, I'm doing the research, and they kind of helped throw out some titles, and they came up with Getting Over Going Under. I didn't check it. I was busy doing the book. I said, that's a great title. I like that title. Let's work on the subtitle. And went along with it. And so when I posted my first post, I didn't expect any interest. I was like, this is so niche, like nobody cares. And that first post I did, that was the 4 drugs that lead to dementia, and my in fact, we got like 2 million views on that on Instagram alone, which is crazy to me.
That's
and
amazing.
People were like, oh my gosh, I had all these anesthesia experiences. But when I posted that, everybody went looking for the book, and they found another book.
Oh no.
With that title.
Oh
by an anesthesiologist.
That's terrible. Oh no.
And I was like, oh my gosh, have I been wasting my time? I'm writing a book that's already been written. Oh my gosh, I didn't even look.
Yeah.
But it was written by this really smart anesthesiologist from Stanford. He's retired now, but he wrote it in the same vein of patient advocacy, right? So he wrote it to make people aware of the problem with anesthesia, the risk of dementia, all the things I was talking about. It just makes my case for me.
Yeah.
But his approach was different. His approach was, talk to your anesthesiologist. Ask them for this. Ask them for that. And the thing about that is anesthesiologists are very passionate about protecting patients. And when they learn something, and that something works, and it won't kill the patient, and it protects the patient, and they make it through anesthesia very smoothly, like meaning no blood pressure changes, no major, like everything's, we've maintained your internal milieu as close to baseline during surgery, which is an accomplishment. When they find what works for them, they don't want to change that, because that's how they safely get a patient through surgery. Yeah. And so the approach to asking your anesthesiologist, that's why I don't answer those questions in my comments, like, what drug should I ask them for? Yeah. What anesthesia should I ask them for?
It's not a restaurant menu where you like pick and choose your thing. It's like during the pandemic, right? Oh, I want this vaccine and I want that vaccine. It's like, who are you to make those decisions?
Right. Right. And so I was like, I don't advocate people to do that. I mean, I want you to self-advocate, but the reality is the safest anesthesia is the one your anesthesia provider is most comfortable giving you. Yeah. And you don't want to mess with that. You just don't want to mess with it. You want to be asleep. You don't want to be paralyzed and awake. You don't want to be asking for something that your body just doesn't handle very well. I've been in that circumstance where I've tried to do a different form of anesthesia because I prefer to give this to them. And their blood pressure just freaking won't come up. And I'm like giving them more drugs to try to fix that. And that's not good. That's polypharmacy. That's never good for you. No. So, I take a different approach. His is good, but he got a lot of pushback. And the point I was making he actually, I interviewed him for my podcast because I thought we were in the same, we want people to know.
Yeah.
One of the things he did advocate for, by the way, and I want your audience to know they can and should advocate for it, was to ask for a brain monitor.
Mm-hmm.
I use it,
Mm-hmm.
but less than 20%, I would say, of anesthesia providers will typically use it.
Why is
unless
that?
it's extensive circumstances. So we know that there are certain surgeries where there's higher risk of awareness during surgery because it's an emergency trauma,
Mm-hmm.
emergency C-section, and like neurosurgery, certain neurosurgeries, and then open heart surgery. Okay, so those four, people might reach for that monitor. In fact, that's sort of the guidance from the American Society of Anesthesiologists. In these circumstances, it might be helpful to have a neuromonitor because there's more risk of awareness. But as a rule, in the rest of the cases that make up the 90% of the rest of your surgeries, like elective surgery, people don't use it. And I think that's ridiculous because you can actually manage to lower the anesthetic dose that the person receives. If you know that they're asleep, you don't necessarily need to give them X amount of gas or X amount of IV medications. You can actually lower that, and that's good for the brain. Less is more.
Yeah.
You know, and so that's something they should advocate for as a brain monitor.
That's really important to know.
Yeah.
Sandy, you mentioned paralyzed but awake. What is that?
But yeah, there was a movie when I graduated from anesthesia school. There was a movie that came out just before. It was called Awake.
I remember that.
Yeah, and every patient asked me, "Am I going to be awake?" Because they saw the movie where the guy literally was, I don't know, I guess I didn't watch it, so I don't know, but I understand he was under open heart surgery and awake, paralyzed, and having his heart operated on. That is terrifying. Okay, it's terrifying for the anesthesia provider. Literally, it's our biggest fear is that we under anesthetize you and now you're paralyzed, vulnerable, hear everything, know everything, feel everything, and can't move. Like that is why I tell people, don't ask your anesthesiologist for the drug that to give you a certain type of anesthesia, because then you're going to take the risk. If they're not comfortable with that, you might experience that. That to me has the most lasting impacts. I recently heard at my job in anesthesia, there was a case. I was talking to the surgeon, and he told me about a case he had with another anesthesia provider where a patient experienced that. And she is utterly disabled, like PTSD, talking about mental health. It is a serious side effect that lasts a long. I mean, brain fog would be nothing compared to the PTSD of being awake and feeling and knowing and hearing. Do you know what I mean? A little bit of awareness when you're under like a colonoscopy, that's different. That's not general anesthesia, and you're not paralyzed and you can move, and that's called sedation anesthesia. It's not total anesthesia.
Yeah,
that's different. You should experience a little. You may hear things that's fine, but under general anesthesia where you're paralyzed and they're actually cutting you open, you need to be asleep. Like that's the whole purpose of my profession.
Absolutely. So. I was awake during breast implant surgery. They did local anesthetic with sedation, and I woke up during the sedation and tried to get off the table, and they were trying to push me back down and put the.
Oh wow!
Since then, I've done videos. I've had the toxic implants out and everything. I know you talk about breast implant.
I had them.
Well,
I had them. This is very personal to me. Like I truly think, so I worked for 10 years in a level 1 trauma center where we did pediatrics, hearts. I did trauma. It was stressful and a lot of occupational exposure while I had breast implants. Okay.
Wow.
I hit 38 and the weight started to come. The hair started to fall out. My skin aged really fast. My husband would look at me and said, "Did you put moisturizer on?" I'm like, "Yes, I did."
Oh,
I don't know why it's so crazy, and it was bad. And I had implants. They were 18 years old.
Wow.
And I knew I needed to get them out because
were they silicone or?
And meanwhile, I had started research about them because I'm in natural health now. I'm going to all these conferences and they're talking about them and how they actually use silicone to clean up oil spills. I mean, it's a natural area in the body that will hold toxins. You will not detox as long as you have implants, and you won't detox what's in those implants.
I know.
Right? So fluorine gas, I did pediatric anesthesia. You know how we do pediatric anesthesia? We bring a baby to the OR and we give them gas. We take the gas like here and we blow it here. So everybody's getting gassed.
Wow.
As we, and the baby cries and it's just gas is escaping everywhere. I did that for 10 years.
Oh my God.
And so it's definitely high occupational exposure. And my brain fog during that year, before I had my implants out, okay, so I wasn't thinking. I got in a sauna. Sauna actually makes it worse. You shouldn't get in a sauna if you're in implants. I literally have a hard time remembering much from that year. I don't know how I worked. I don't know how I did anything in my life. I don't remember much because I literally felt like I had dementia. And as soon as my implants came out,
Things
it was
changed.
dramatically different. I was still sleepy under the effects of the anesthesia, but I knew my brain was firing different. So get the implants out if you have them.
Good for you. I mean, I had the silicone implants, they ruptured, and I was on the table for 12 hours while they were trying to clean out the silicone that was everywhere, just migrated everywhere. So I don't know what's left in my body. And then we switched to saline, and then I had those out, and they were black, literally black, with mold.
Wow.
So can you imagine what's going on inside
Your
my
body?
body?
Oh, your
It's a
body.
miracle that I'm still here. But you know what? We should
Wow.
definitely do like another episode and maybe talk about breast implants and talk about our stories.
Mine
and
was ruptured
everything.
too.
Yours
Mine was ruptured
too.
too. But by the grace of God, I had worked. So I was in the holistic space, like really in the conferences and meeting other people and connecting, kind of in that space. Praise God. And so I met another PA that's her thing. Like breast implant illness is her thing. She has a whole protocol and everything. And she's like, you need to make sure you meet a surgeon that does it this way. And I was like, oh. So, they basically, and the shorter
capsule,
answer is
right?
the en bloc, So they shouldn't be scooping out silicone. They should have taken the whole
Well, this was a
capsule out.
dentist doing it because I was living in Florida, and like dentists or anyone can practice plastic surgery. So it was
What?
Yeah.
I did not know
Yeah,
that.
back then, this was like 20 something years ago.
Oh, okay.
And I mean, I was in the dentist chair or in his office and on the table for 12 hours
Oh
under
my
local
gosh.
anesthetic while he's trying to scrape out all the silicone. I mean, it's
My God.
so this was after waking up during the first surgery. Then this was my second surgery, and then the third surgery, they finally came out the black silicone. I mean, the saline implants that were black with mold. So I mean, and still
I
to
bet
this
you
day,
feel like a different person. I bet you feel like a totally different person.
Absolutely.
Yeah.
But I had to do a lot of work on myself to be as healthy as I am. But I still, and I'm breastfed like that, and I think, oh my God, like what did I do to my son? And
Oh, me too.
you too.
Hey,
And
look, my kids, interestingly, my last two, which I think my implants were ruptured during the last two, because I have 5, like the last two. The fourth one was okay, my husband's not huge. He's a Native American, so he's kind of from a small tribe that's got small, they're Creek Indians, so they're smaller.
yeah.
So my fourth is a boy who looks just like his dad. He's not really big. He's smaller structured, but he was in the less than 5th percentile in growth curve. Like it was abnormal. And my fourth, which I think may have been related to somewhat to my implants. And then my fifth one, which is my only girl, she had the worst problems with her gut biome and her liver. I mean, I knew there was something wrong with her gut and her liver. Her poop was not in the right, it was clay colored. It wasn't normal. Like she wasn't making bilirubin.
Yeah.
And I really do think I stressed her liver from the silicone, because that's what it does to you, is it stresses your liver.
Absolutely. Absolutely.
Yeah.
Well, we
Sorry,
definitely
we wanted a
you need
breast
to come
implant.
back. We need to have a good conversation about this, because this is also something that women need to know. And I see a lot of women now in their 50s going out to get breast implants because you can't live with small boobs. So I think let's definitely talk about this next time.
For sure.
Dr. Sande, please tell our listeners where they can find you, where they can find your book, how they can learn more about you, how they can follow you on Instagram.
Yeah. So my website is beyondbrainhealth.com, and you can certainly, I recommend you get on that newsletter, because I send everything out, like education and all the announcements come out there first before Instagram. But Instagram is at Beyond Brain Health, Facebook is at Beyond Brain Health, and I think TikTok is Dr. Sande I think YouTube is Sandy B PhD. Let's see what else. What other handles do I have? Those are the main ones.
I'll make sure to link everything below so they can find you easily.
I don't have anything on Twitter or X or whatever that is. I haven't.
They would like you there. They would
bridged that world yet. I don't know they would. I think I'd get a lot of. I think I'd hear more from my colleagues in Twitter.
It could be. That is possible. Thank you so much, Dr. Sande. It was absolutely mind-blowing, mind-opening conversation. I really, really appreciate your time. Thank you so much for being here.
Thanks again for having me. Such a fun conversation.
Really great conversation. Thank you everyone for listening, and don't forget to like and subscribe, and we'll see you guys in the next one.